Thank you.
Okay, so I think you have now coached me up. And what I don't know is whether we have everybody that we're expecting.
I think Dina is going to be on her way soon. She had a client she was finishing with.
So we'll give a moment or so. Since I have not been part of the trainings up until now, let me introduce myself for folks who may not know me. I'm Mark Snowden, a professor here in the Department of Psychiatry and an investigator with the Health Promotion Research Center, and have been the supervisor for the local PEARLS teams, probably for 15 years or so now. And in the past was probably a more active participant in these trainings, but between Leslie and Caitlin, they don't need me to do as much anymore, so you don't get to see me as much. But
That's true. You're just even more busy than we are.
that's true. That's true. But they're pulling me off of the bench today to come in and help out. So I'm going to do the session today. Why don't you guys tell me who you are? Cynthia, I recognize you from TA calls.
Hi, yeah, I'm Cynthia Margiotto with the PEARLS program of Colorado. We're the first PEARLS program here in Colorado, and I'm hoping to get more of the PEARLS programs going and start it out here.
Excellent. Excellent.
Hi, Dr. Snowden. I'm Andrea Deaton. I'm a marriage and family therapist, and I serve as a staff development officer at Riverside University Health System Behavioral Health, or County of Riverside Behavioral Health. And I work in our prevention and early intervention unit. And we actually fund the PEARLS program in Riverside County for our community-based provider, Inland Caregiver Resource Center. So I provide technical assistance and training and fidelity oversight to the provider for this evidence-based practice and a number of other ones that are implemented in our county.
Excellent. Excellent. Thanks.
And I'm Allison Handline. I'm at the Traeger Clinic in Louisville, Kentucky. And we are a primary care clinic that combines, well, primary care for physical health, but also mental health services. And we try to be a wraparound for older adults in our county and the surrounding 6 counties. And I've been doing PEARLS for a couple years now, I think almost. So I'm excited to train more people.
Excellent. And Dina?
I apologize, I'm a few minutes late. I went over a little bit with the patient, so I apologize. Yeah, I am also at the Traeger Institute in Louisville, Kentucky with Allison, and she and I have both been doing PEARLS with clients for a couple of years now, and are excited about being able to train. We have, 50 or 60 students that we onboard each year for multiple disciplines that we also can train to be PEARLS counselors. So we're really excited about doing that.
Excellent. Excellent. Well, I'm glad to be here. We have an hour and a half to cover several topics. So let me start moving us through in terms of the objectives. We're going to talk about suicide and self-harm action plans. We're going to spend time talking about how you, in training, make the case for clinical supervision, and then more specifically, how to begin helping future coaches learn how to work with a clinical supervisor, including examples on case presentations. And then the last major topic for today is to cover what happens in the final PEARLS session, because similar to the first session, it's not just a normal working session. So there are a few things you have to remind people that they will need to be able to do. In terms of the adult learning objectives, this was focused more on gauging the level of engagement or lack thereof from your learners. And I would say that certainly when we first created these slides and these topics, we were in an in-person world of training. It's probably even more complicated in my experience over Zoom to really gauge engagement, because it's much easier for people to be distracted by other things that are happening other than just what's even in the room. So clearly, when people are engaged, you get some sense that they are nodding and responding to what you were saying in sort of real time. They're able to make eye contact. They look interested. They ask questions that are relevant to what you've been going over. They sort of lean in, so to speak. Oftentimes people will share their own experiences that give you the sense that they are able to relate what you are talking about to them in a very specific kind of way. And certainly when you do practice sessions and activities, you can really see that they're able to try them on their own based on what you've given them, or add to the information you gave. In terms of telling when people are not engaged, it's a little harder. Split screens in Zoom, I've decided, are not necessarily the way to know, depending on where people put their cameras and where they decide they want to have their viewing screen. The fact that they're not looking at the camera doesn't necessarily mean that they aren't engaged. But again, you have no idea of really what's happening outside of what you can see on the screen in terms of what they're looking at or what they're doing with their hands. Certainly when you can see their hands, you have a sense that they're not at least typing, but it's really hard to tell in the Zoom world. Clearly, even on Zoom, people who are shrugging and yawning, people where you can hear other stuff going on in the background that makes you think they're distracted. I think we've often encouraged people to keep their cameras on so that we have some sense of being able to see them and know that they're not doing other things. So those are all kinds of things that you can use to try to get a sense of how engaged people are with you or not. Other things that you guys have noticed, particularly in this Zoom world that many of us have been in, that give you a sense of how to tell when people are engaged or not engaged.
I will say that in some instances, the fact that there is the chat feature in Zoom, I think there have been some folks that have actually engaged maybe more because they don't have to actually speak in front of people.
It's true.
Well, and frowning and the typing thing where there's a lot of chatter, where you see, because you have that option to chat. And then you see, Sam sending a message to Joe, hey, what are you doing for dinner? That's
Yeah,
a real pain.
that does happen. Yeah, I think I've been impressed with the fact that with the chat feature in particular, that people really are prone to multitasking. Even if they're chatting about what's happening in the talk, the fact that there could be a completely separate conversation going on is still a little bit disorienting to me, since I'm not one who finds that I can chat and really pay attention or present information at the same time. But I have colleagues who seem to do it with ease almost.
They say that multitasking, it doesn't really work.
It's true. You can think that you are truly paying attention and doing two things at once, but in reality, you're never really doing two things at once. That's true. Okay. In terms of teach backs, at the end of the day sessions, what we really hope is that you would be able to describe your action steps for what a PEARLS counselor would need to take away from your training on what to do with a suicidal client. And then to be able to describe the rationale that you would give for clinical supervision and what are the key components of a case presentation for review and supervision. This is a slide I think that just reminds everybody of where the materials that we're covering today can be found and what you have. Is this where we need to also remind folks, Caitlin, that the article that we normally gave is really not going to work for them? Maybe they already
Yeah, sure. So there was an article that you may have seen if you checked PH Learn Link basically before yesterday. Um, it was the Joint Commission, what was it, suicide alert assessment that we used to link as homework before this session. And as we were testing it out, we realized it doesn't work anymore. So after a little bit of digging, we realized it's because they're not using that anymore. So I took the link down yesterday. And Mark, did you find something you wanted
We'll
to?
give you something more.
We'll send something afterwards. Yeah.
Thanks, Caitlin. So let's dive into the training about suicide. I think what I like to try to do is to make the case before you get into the details of why this is something that people will have to do. And the challenge is to do it in a way that makes the necessity clear, but doesn't scare people so much that they begin to believe that this is not a program for them because they don't want to be responsible for somebody who might kill themselves. And so you do have to walk this balance of giving people information, but making it clear to them that they can, in fact, I think, manage this. And one way to do it is to see if, based on the work that they're already doing, they've already had to come up with a procedure that they have in place, because it's much easier to start with something that's there than to develop it from scratch. After that, I usually tell folks that the standard that they are held to is really, I think, an agency standard. The fact that they are taking on curls and maybe working as a coach doesn't necessarily mean that they have to work at a standard that would apply to a psychiatrist, for instance, or a psychologist, for instance. I think that's another way of trying to put them a little bit at ease, that they can manage this as long as they keep in mind where they really are and don't assume a greater responsibility than it's truly there. After that, it's pretty easy to connect the dots that depressed people sometimes become suicidal. And it's one of the reasons, I think, from a public health perspective, that treatments like pearls for depression are important. And that we like to try to talk about it in a normalized kind of way in pearls. And that therefore everybody who's potentially going to be involved with the client might need to know what to do if suicidality comes up. Having people know what resources they have both within their agency and particularly outside is helpful. And when I was doing the training, we tried to make sure we always gave, if nothing else, the National Suicide Prevention Hotline number, because no matter where you are, everybody can use that number to give to a client, and it works 24/7. As you may know, it's federally mandated that by July of next year, nationally, we're going to move from the 10-digit suicide prevention hotline number to a 988 system. And so it should be much easier for people to know what number to give for somebody who might be suicidal to call, because it'll just be 3 digits that should work wherever you are in the country.
I didn't know that.
Oh, yes, it was
I have a
passed
suicide.
in
Yeah,
the federal legislation a year or so ago, and the date is, I think, July 21st or something like that. Many states are well on their way of putting it into process. And here in Washington State, in addition to rolling out the 988 number, they're also using it as an opportunity to revamp and revisit the entire behavioral health crisis response system. So looking at mobile outreach for folks, as well as what is the array of crisis clinics that people have access to. So much bigger sort of process. Lastly, I think it's important again to put this in the context of, you're just training and giving an overview. You're not trying to make people feel like their plans will be exhaustive, or that in fact they will be independent experts in managing suicidal patients. And in fact, I try to say that's not what I'm doing when I do the training, so that there's no confusion about what my goals are. In terms of when to think about it, it's pretty easy when you do the PHQ-9. The question 9 is the one is the standard that might bring this up. I think there are other instances when people are talking even outside of the PHQ-9 where suicidality may come up. So I think it is important to train people that it's not just the PHQ-9, but you do have to have your antennas up in other stuff that people say in the course of working with them. In terms of the basics of assessments, again, we want to be able to start with them knowing what to do. And I think putting this in the framework of there are sort of 3 buckets that you should be able to feel like at the end of the day, you know about. Is the person really just having an idea? Are they talking about something that they intend to do? Or are there actions that have already in fact been taken in terms of planning? And if people can, at the end of their protocol, whatever the details turn out to be, because you won't be there for all the details, if at the end of the day, they can say where a person is in terms of those 3 buckets, then you've probably trained them to do what they need to be able to do to then move to the next step of their protocol. And I explain this by saying that we believe that as you go from ideation to action is how people go from being lower risk to being higher risk. We give materials. I believe this is in the materials that we provide you, that you can provide others, that go into many more specifics around the thoughts and behaviors and where they fit with the risk categories. But again, in a simplified way, the previous slide and the 3 buckets, I think, are the clearest way to start. When you move in this diagram to the bottom row, is where I think people sometimes do need help in terms of thinking through the specific types of questions that I might need to ask. And so giving them specific language to use. Do you have a plan? How would you do it? When would you do it? Where would you think about doing it? For means, it's fine for them to use the word means, but you may come up with other things in terms of, do you have in your possession, or do you have access to guns or medications? Because I work in a hospital with an emergency department, we are of the mind that everybody who walks into the emergency department, in theory, has a means to kill themselves. If they really want to, they can go out and find a means. But what you're really trying to do is to figure out what is on the person's mind. What are they most likely to do? Not just, are there any possible ways and avenues? And then finally, have they done anything to prepare? Have they made what we would call rehearsal behaviors in any specific timeline? So it's a busy slide, but again, I think it's really there for you to be able to provide information that they can use in the future. Not that they're going to really remember everything that you might say about this. Let me pause here just to see if there are any questions or concerns that you guys have about the thought of trying to present this to other people, or potentially even in your own work today. Okay. Consultation. Doing supervision is something that I've enjoyed, like I say, for over a decade now, probably coming up on 2 decades. And I think from the supervisor's perspective, it's a different way of helping clients than when I do direct patient care. I still do see patients in my own practices, and so it's not only through a supervision role, but this is the main thing that I do in a PEARLS context. For me, I was a supervisee through all my years of medical school and residency training. And at some point along the way, you begin to supervise others in this. So I came to it with some senses of what I thought good supervisors were like, but not so good supervisors were like. I think sharing your experience with folks that you're training to sort of give them a fuller scope of why this is important can be helpful. The practical reason that many agencies need a clinical supervisor is that they don't have somebody in-house who's truly prepared to help walk them through what to do with a suicidal client. So it's easy for me to understand that that's the main reason they might want me. In reality, though, if you were to ever get asked the question, well, how often does that really come up? In reality, it doesn't come up very often at all. The most I deal with are people who on their PHQ-9 say that they have times where they think about death or they have passive suicidality. But the number of times where we actually truly have to work a protocol and deal with somebody who has a plan or intent or has taken some type of action is really very, very rare. But that's, again, one of the roles. So most agencies will want to loop in working with the clinical supervisor as part of their procedure. Because we often, I see a hand was raised there.
I'm sorry. The one that says has the client informed other providers.
Yep.
On our sheet that we have, that's a Pearl sheet, it asks, and I can't remember what page it is, but whether or not we can contact their provider to let them know they're working with us.
Correct.
Most of the people I work with, and maybe it's because we're partly rural, and I don't mean to be stereotyping, but most people say, I don't want you telling anybody.
Yeah.
You know, how do we, so they don't even give me the name of their provider or anybody they're working with.
Sure, and that's perfectly fine. Again, it's not required now that people give their primary care provider. In the original Pearls trial, to have been in our very first study, you had to give access to your primary care provider. But that's one of the things that we've learned is not such high fidelity value that it has to be done. So this question is here really just to get information. It's not to say that they must have done that or that you must talk to their provider. But I think the reason we're asking it is that what I would tell a coach is if they've shared it not only with you, but they've also shared it with their primary care provider, then you know that there is someone else out there that's also working this and is somewhat responsible. It doesn't mean that you're not going to follow the agency protocol that's been developed, but at least you know there's somebody else that's also had to think about what to do with this. Whereas if it becomes clear they've not shared it with anybody else, then you really know it's going to be up to them and their agency's protocol to do what's going to be necessary.
Thank you.
I think the second bullet under that question is, even if originally they said they didn't want you to ask or talk to their primary care provider, if this were to come up, this is a reasonable time to ask the question again. And they may still say no, and you would still respect their wish. Similarly, I've had clients that are working with coaches I supervise who say no initially, and then it turns out their depression is such that I think medications are warranted. So I say this is another time to go back to them, even though initially they said no, just to see if they've changed their mind. Because people, they might, and certainly once they've gotten to know you and know that you're not really going to be trying to get all of the intimate details of their life, they may be much more comfortable with you talking to their primary care provider than when you first asked before there was that relationship. Does that help?
Yes, thank you.
Okay.
Thank you.
So yeah, we want to develop a safety plan with the client. We're going to ask about, have they talked to other providers, particularly primary care? In my practice, people that had histories of either recent psychiatric admissions for depression or recent suicide attempts, if they are in PEARLS, I've requested that they also be getting mental health treatment from somebody else. So that again, the PEARLS team is not the only place that's trying to deal with somebody that might have needs that go beyond sort of the working relationship that PEARLS counselors are going to have. Again, we're going to provide emergency numbers as part of this procedure that we get at. And depending on what the person has said and where you are, again, you may be called to try to help get the client to a safer place to be evaluated or to potentially call the police. In my experience, I've only had one PEARLS coach who on 2 separate occasions did have to call in the Seattle King County area the people that are responsible for going out and seeing someone in their home if we are concerned that they're going to hurt themselves. So again, that's a very local procedure and resource that again might not even be available to somebody in a different state in Washington. The last part, again, is documenting. Most agencies for this particular risk issue do want to make sure that things are appropriately documented. I'm dealing with a recent case, though, in our own medical system where I think you do have to still be cautious about what is put into the record. So I think it's fine to talk about the things that you were concerned about and the risks. I think you again want to always exercise caution in putting in details that identify things about the client that the client may really be uncomfortable in a medical record. So I teach residents and students that I supervise that it's a fine art to learn sort of how much to document, but then how much not to document, because a lot of clients, I think, have this fear that the intimate details of their life are now recorded in a medical record. And most of the time, that's not what you really need from a risk management standpoint. So saying that a person has a plan, what their plan is, would be, I think, appropriate. Trying to get into the names of other people that they might be mentioning may be completely erroneous and not necessary, even though they might tell you about things that they plan to do or people that they plan to talk to. Again, those are the kinds of things that I think can upset people. Certainly, if they are talking about hurting somebody else in addition to themselves, that may become very relevant. But I think you do have to still be cautious about what you tell people to document in terms of a level of detail. Okay. This is the protocol that's in the workbook. It's sort of fine print, but again, the first part of the procedure over here is to ask the client if they have a plan on how they might harm themselves. I think in the frequently asked questions for this session, we sometimes say that it is still the case that some people will ask you, is asking about this and digging into the details going to make the person more likely to harm themselves? And the answer has been a pretty definitive no. If anything, this is going to, I think, normalize the discussion and, in fact, help them rather than hurt them. And so there's nothing about asking these questions that the person that you're training should be afraid of. It then goes through what to do in terms of if they've informed somebody and they give you permission, this becomes a resource so that you can get potentially another person's take on what was said and the degree of intent and planning that the other person learned about versus what you have heard about. If again, they've said something and they've given you permission to talk to them. So that's what I think you can tell your future sort of students or coaches that are being trained about why you want to do this. And then the last point again is, again, if there is a sense that you're at an imminence point, there is a plan, there is a means, there seems to be an intent, that's when you have to think about other steps to be taken in terms of calling for immediate help. For the people that I supervise, I make it clear to them that if the person has a history, that's the next most important thing that I need to know about. So this plan tells you what to do with the thing at hand. Before they call me, I want to make sure that they also ask the question about, have you ever in the past tried to hurt yourself? Because as the supervisor, that's the next most important piece of information that I need to know beyond the basics of what we covered here. Not all supervisors would be that way, but that's the way I like to work with my coaches in terms of doing risk assessment. Okay, question, Andrew?
Yes, this document kind of blends suicide risk and self-harm kind of together into one concept. And there's a lot of movement in the field around suicide prevention, and talking about self-harm and suicide is actually two separate issues. So is it okay if, like with my provider, if I reword some of this to be more clear about suicide versus self-harm?
Sure.
Okay.
I think that's fine. I mean, again, I think at the coaches level, it really depends on what the agency standard is. So what I would say to people is, there are some places where this is a big distinction between self-harm acts and suicide acts. There are other places where they would say it's all high risk to me, and so we're not going to make that separation. So
Okay.
again, if you're working at a place where that's again the standard, perfectly appropriate.
Okay.
And one of the things we like about the way we try to do this is that we give the flexibility for people to modify things to fit where they really are.
Okay, thank you.
Sure. Other questions or thoughts? The limits that you see in trying to train people in how to do this?
The one thing I added on mine was that our crisis line number for our folks.
Yep.
I thought that to be honest, I pulled it right out of here and used it for myself, for my own program.
I think that's great.
Yeah.
Yeah, I think most plans, in terms of, if you look at what the agency is trying to do, not just what you're trying to do, what most agencies I think want to be able to do is to be able to say that they asked some basic questions and they made some assessment over the imminence. Whether they had to get a clinical supervisor involved or not doesn't matter, but that somebody decided whether this was imminent risk or not, and then what was the plan. And if it's not imminent, then it's perfectly appropriate that all you may need to do is to tell the person what to do if in fact things change between now and the next time I see or talk to you. And that's where giving a number can be very helpful. If you can document that you gave something concrete, most agencies feel really good about that. If you can document that you told somebody where to go, that may be the next best thing. And so we often teach, document what you told them to do. And I try to teach this in terms of, it's a common enough thing that from a prevention standpoint, I think that's the biggest change since I've been in practice. It used to be that we mostly focused on the risk in the here and now. And if you were only saying you had passive SI, then I didn't need to do anything. And now what we know is that that's a very fluid situation, and that many people change fairly quickly after having seen somebody. So we've got to now prepare for, what do you tell them to do when this is likely to have changed? And that's where giving that information number or where to go becomes really helpful as part of the plan.
It's also somewhat about like reteaching people how to respond when they hear the word suicide. Most folks, myself included, even though I've been, in practice for 15 years as an MFT, panic a little bit when someone says they're having thoughts of suicide. And most of us immediately jump to, I have to call 911 because the word suicide was ever mentioned, brought up, or hinted at, and kind of retraining people that while that might be the outcome that needs to happen for some people, for most people, that's not what needs to happen. That there are so many things we can do before emergency response, hospitalization, and all of those other higher level of care things come into play, like providing that suicide prevention lifeline phone number, like working on a safety plan that's pretty basic and simple, but gets them connected to supports and resources, is so much more effective than just hospitalizing people. And so it's retraining folks that, while yes, the concept is scary and it brings up our own values, our own judgments, our own ideas, our beliefs come into the conversation, there's so many things that we can do that don't involve hospitalizing someone or calling 911.
It's very true. It's very true. Hearing you say that reminds me that I think another thing that you can sometimes help to tell people is sort of the last extension of what I said about, please reassure people that they're not going to make somebody suicidal by asking these questions. I think it's not untrue to actually go so far as to say, for many people, having a discussion actually relieves them, because for many people, they really think that something is seriously, seriously wrong with them if they've had these thoughts. And if you can put those thoughts in a context that now lets them know that it's not unusual for people who are depressed or going through this, and that they actually do have other alternatives, that can actually make them feel much better than when they had this all bottled up inside and thought something was really, really wrong with them. Okay. This is the last list of resources. And like I say, I do believe that hopefully in the near future, giving people simply a 988 card may be much simpler than the longer suicide hotline number. Okay. Last chance for now, at least, for questions about the suicide protocol part of things. Okay, so let's move into clinical supervision. This is showing you where the things are. And I do remember from all the sessions I had that the lilac sheets were my sheets. So it's good to see it's still lilac. What I do in my sessions in training is to try to go through the why, what, how sort of dynamic for this. And I do think, because this is a place most programs are going to have to spend some money, that you don't want to shortcut the why part. It may be crystal clear to you, but for some places you're going to have to make a case, because this is where they're going to have to spend some money in all likelihood in terms of having a clinical supervisor. We then can move into talking about what the supervisor does and how to most effectively use the supervision, given that it is a cost that the agency is going to have to support. I said a little bit before that I don't think managing suicidal clients is really the best reason for paying me to be a supervisor, because it's just a pretty rare thing. The real reason to pay me to be a supervisor or somebody else to be a supervisor is that you get additional perspectives, particularly for managing complicated clients or patients, people that are having less improvement maybe than we would like. many coaches, I think, benefit from having someone that's not face-to-face or in the home to give a slightly distanced perspective. I think sometimes you can get too close to an issue to really be able to look at it the way you would like. And so I often tell them that's what I do. And it's not that there's something magical that I know as a supervisor. It's just that I'm not bombarded with what they're bombarded with, which means that my mind can go to places that their mind doesn't go because I'm not really in the midst of it with them. Certainly, I think if you were to talk to the people that I've supervised, they like the fact that I can teach them about some of the medical things that come to play with clients. We certainly talk about medications. But as one who's also trained in psychotherapy, I can give them perspectives on how to alter their approaches to problem solving therapy and to behavioral activation, because I do that with my own clients. Again, it's a given that this helps with a liability issue, and we talked about managing SI. The last thing I do is I speak to the fact that for as great as the trainings that we do and the trainings that you guys are going to do are, people never learn everything that they need to know in the training. And supervision becomes a way to reinforce what was presented in the training or to potentially further develop the skills that we tried to initiate in the training. So supervision sort of allows you to continue training and development. I give my own examples as a supervisor of how I do it. So don't think that this is set in stone, but again, it gives people at least some concrete ways to approach how to use the time that they are paying for to potentially be really efficient. And so what I say is I like to hear about all of the new cases at least once. And then I want to hear about the ongoing cases, particularly those that are not progressing as desired. Where time permits, it's always good to review some success stories. But again, the real reason to pay me as a supervisor is not to tell me about everything that's going great, but to be able to use me for cases that aren't going as great as we would like. And we all have those. The challenge is, especially if you do this in a group format, is how to get people comfortable talking about the cases that are not going well, because nobody wants to talk about those. They want to talk about the successes. And so trying to normalize talking about cases that aren't going well is the challenge that the supervisor will have. I think if you can train people that it's a normal thing that you have to get over, but it's a good thing to get over quickly, that's probably the most you can do in your trainings. For the case presentations, my mantra for all the years I've done this is less is more. Because I think many people, their preconceived notion of what they have to prepare for a supervisor is way more information than most supervisors really need at the moment in time. And so getting this across to them is, I think, really key. It's hard for people to do it on a regular basis, but I think giving them the bar and the goal that they want to be able to think about presenting a case in roughly 2 to 3 minutes, again, is perfectly appropriate. If the person goes much over 5 minutes, it's actually distracting for me because they're probably telling me stuff that I didn't need to know, and I'm looking for stuff that they probably haven't said. And so it actually starts to get me on edge if it goes on for too long, because I'm waiting for stuff that I wanted to have heard probably a couple of minutes ago. The easiest way, since this is one of the things that to me puts me at ease, is to give them a concrete structure for how to do this. Now, would all supervisors say they need that? No, I'm more than happy to admit that this may be my particular quirk as a supervisor. But I do find that it puts me at ease, and I think it does help people sort of have some sense of what they should be doing. Not that many people do it this way all the time, but I like to have been able to give them a structure. To the extent that you guys maybe work with supervisors, are there particular things that you find that from your own personal experience you would want to bring to this part in terms of the key points of working with supervisors or doing case presentations?
I
Cynthia?
have a nurse practitioner and a psychologist, both of them. Yeah, I have to rein them in.
Oh.
They want to know way, life story stuff, and I'm like, I don't know. And so what I have done is that I use the form that, where is it? Sitting over there, the form that Pearls gave us, and put some details on there that I give to them. And then I have 2 or 3 sentences on each client that I type out, and I give them a copy of that. And if they want more information, then they can ask for more, but that really keeps it condensed more,
Mhm.
because they are very expensive. You're right, Doc.
Yep.
So I try to keep it down, but that seems to work really well with these 2 folks.
Good. Others have things to share?
I overshare. They all know it. Sorry.
Okay. We haven't done it very often, but I have volunteered at times to do a session for supervisors, because you raise a very good point, Cynthia. Depending on how long ago the person trained, many folks don't know how to do this type of program. Most psychiatry residency programs nowadays teach people in training how to do what we call integrated care. And so they get trained to know what a psychiatrist that's working as a supervisor in an integrated care model does. And so this notion that you don't need to know everything about a client is not going to be new to them. But if you had somebody that did their training 20 years ago and never heard of integrated care, then they may not know that Pearls is not the type of program that starts off getting everybody's detailed life history. So I think being able to teach your future trainees that they may need to do some orientation of their supervisor about what Pearls really is, so that that person comes into this knowing that we are really a here and now program and not a program that's trying to learn everybody's life story, will be helpful to making the supervision go better.
I think that it took me a couple months to figure out that I needed to do that with these 2.
Again, I'm happy if there have been some programs that are in their startup period. The supervisor wants to speak to me to get some sense of what does it mean to be a Pearls supervisor. So when that comes up, certainly feel free to write or have your trainees write to Leslie or Caitlin, because again, I'm happy to talk to people about what being a Pearls supervisor is like and what they don't need to do.
Our provider did that. The provider that they were looking to, or the supervisor they wanted to contract with, really had some questions and spent some time on the phone with you, Dr. Snowden, and that relationship now, it has been so smooth and seamless, and they get so much great support from Dr. Day as a result of him being able to consult with you to kind of figure out and get his bearings, since he wasn't going to be seeing the clients that our Pearls program is seeing. That step of being removed is, while it's super helpful, it also creates a lot of, I think, apprehension for some folks. And so your support with Dr. Day was really invaluable to my provider, and that they've been working so well together now as a result of that.
That's good. That's good. Okay. So this is the outline for the presentation that I give, and I guess I don't know that any of you actually had me. I didn't do any of the trainings that you guys did, I don't think. So you never heard me do this. Okay, so what I always tell people is that I'm old school enough that if you don't tell me the person's age within probably the first 30 seconds, I really get anxious because even as a geriatric psychiatrist, there's a big difference in my world between a 60-year-old and an 80-year-old or a 90-year-old. And so I just need to be able to lock in on where we're talking about. And that's usually the first thing. Many times I get it off of the tracking sheet because I get the tracking sheet that has all 8 sessions and the space for the PHQ-9. And in the top left-hand section of that, it'll have basic demographics on the client. And so if they haven't said it, I usually look down at the sheet and read it off, and then I'm at ease. I think the hardest thing for many people to do is to not immediately move into the psychosocial part, because that's the part that's most interesting to folks. And that's the part that explains why people are being depressed. And so reminding them that there are just a couple things I would like to get before you get into those parts of the story is helpful. Again, the tracking sheet will often tell me the information, but knowing how depressed the person is the next thing that I really want to know after age. Because again, there's a big difference in somebody who's got minor depression versus major depression. And a PHQ-9 that's in the 20s is very different than a PHQ-9 score that's 10 or less. And so I want to know how severe is the depression. And then after that, I'm pretty relaxed. And you can probably go anywhere in this list, and I will be perfectly comfortable following along. The psychosocial stressors are the things that are driving the depression. And so that's a natural thing for people to want to move into next. I can read the problem list off of the tracking sheet. And if it's not there, most coaches, even if they're not medically trained, can tell me the basics of what I need to know about that. Because older adults take a lot of medications, I do tell people that I don't necessarily need to know all the medications, but I do want to know psychotropic medications or meds that are being prescribed for behavioral health problems. The awkward point that we have is many people don't put those on the sheet. And so then we end up in them trying to pronounce these very long and complicated meds. And so what I usually tell people is it's not urgent that I get it right now. And if they want to write it out and just send it to me over email, then that's perfectly fine. I can help them usually with the pronunciations, but it's not a place for people to have to feel anxious or awkward because they don't know how to pronounce all of these meds that people might be on. I like to know a little bit about if they have a mental health treatment history, what it is, and then if there are other aspects of their social history that I need to know. And then in the perfect world, we end this presentation by talking about not just the immediate thing that the person might want to work on, but what would a longer problem list look like? Because at times, as a supervisor, when coaches say to me that they're struggling to know what to do with a client, I go back to the problem list and remind them that, oh, the person at the beginning said that this might be something they would want to work on. Other things that in your experience need to be added to this or taken out based on your work with supervisors?
I know a lot of the time when we've met with our supervisor in the past, they want to know, I guess, sort of like employment status or like what they like to spend their time doing, because that can be a good anchor for people. So usually they ask about that.
Yep.
So that's something we just kind of include.
Yeah, good point. Yeah, in the PHQ-9, we tend to ask about loss of interest and pleasure, but it's also good to know what things are pleasurable and enjoyable for clients. Okay. This is the case example, and when I do the trainings, I usually ask people how long they think a normal presentation would go, and and then I demonstrate by essentially reading this. I used to do it from memory, but because we wanted other people to be able to do this who don't necessarily memorize presentations the way I have, we've now just written it out literally word for word. And again, most groups are somewhat surprised that you can be pretty succinct. But this essentially just walks through everything that was in the outline that I just gave you. If you ask me, what are the things that the coaches that I work with most often leave out? They usually don't tell me the PHQ-9 score or feel comfortable classifying people's depression into minor or major or not. But again, I can figure that out from the tracking sheet. And then, like I say, we do struggle with this issue about the meds and what they can or cannot say to me about the medications at the time. Okay. All right. Some nitty-gritty questions that come up from the trainings that I've done. People will ask about in-person versus teleconferencing, and now in the world of Zoom, we've proven beyond a shadow of a doubt that you can do this via teleconference now. So that's really a pretty easy thing. I am available. I think most supervision contracts do try to say how available will the person be outside of the scheduled contacts. And again, I think in the perfect world, you want to at least have a phone number or an email so that if something comes up between supervision sessions, particularly with somebody who might be suicidal, you have a means of reaching the supervisor. The frequency can really vary. And again, this is driven in large part by the anticipated caseload, what is the budget that the agency has. And so the notion that it has to be weekly is really just not true. And there are very few supervision sessions that I've had that are weekly. Most of the time, it's twice a month in my practice. A question that supervisors have, to the extent that I have talked to supervisors in the past, is who documents the supervision? And again, because most supervisors will never have any direct contact with the client, the way I have recommended is that the agency own the responsibility for documenting stuff, because it's in their interest to have done this. And if you were to say to me, you want me to provide a documentation record of the supervision that I'm providing, that's just going to cost you more money, because the time that I have to spend documented, I'm going to have to charge you for. So what I tell people is, if we are doing something in supervision that you think is really important to managing your legal risk, you should make sure that you're documenting in your agency's record, because I'm not documenting. I keep my own notes on my own tracking charts, but I'm not necessarily documenting every single thing that is discussed. Payment, again, I think most people are going to have the most success by trying to find a supervisor who's willing to work on an hourly consultation basis. Most people aren't going to have somebody that's in-house that they're already paying, that's a psychiatrist or a psychologist. They may have a master's level therapist who can provide the supervision for the PST part, but most agencies as CBOs, community-based organizations, don't have a doctor that's on staff. So they're going to have that contract. We spend a lot of time now trying to break the expectation that you have to get a psychiatrist. I think it's ideal if you can get a psychiatrist, but there are other ways, as Cynthia gave the example of piecing together the supervision that might not involve a psychiatrist. And so what I try to teach is, it's more important to know what are the roles that the supervisor has to play. And if you can find somebody that covers each aspect for each role, then that can work. And so again, a nurse practitioner knows about med, knows about medical problems, can speak to those kind of issues pretty well. So it doesn't have to be a psychiatrist. Any questions about supervision?
Art, can I just add something to that?
Sure.
So if you are offering a training outside of your organization, just in your area or region, you will get questions about, oh, who can I use for a clinical supervisor? And that can be a really hard piece for people to be able to figure out. You know, they may or may not have connections to health organizations or universities nearby, which are sources that we often recommend. So if you know of other active Pearls programs, or you use somebody at your organization who might be willing to contract out, just sort of keeping either a log or a mental log of people who are interested and willing to provide that service to others, even outside of your organization or their own organization. That's a huge help. I mean, Leslie and I try to make those connections, but it's really hard for us to do from Seattle. I mean, once in a while we know of somebody who's able to provide that service, even by Zoom across state lines. It sort of depends on the state and the, you know, scope of practice for whatever that person's title and role is. But just something to keep in mind, because if you train anybody outside of your org, it is going to come up. So just a thought. Thank you.
Sure. Any other questions or comments? Supervision piece. Okay. So the final session, that's where you'll find the information. The goal is to remind people that we want session 8 to be similar to the previous sessions in terms of you're going to do problem solving therapy and behavioral activation, and schedule pleasant events, but that there are some additional things that we want to do. And part of this is to begin the process of review for the client, because for most people, this is the last in-person, face-to-face session. What comes afterwards would be phone check-ins that are designed to be much briefer. By way of the review, I think it's helpful to take the sort of 20,000 foot level and talk about progress made in broad strokes in the sessions. You can start off by looking at the score from beginning to end. And I do that oftentimes in my own supervision when it's the last session, just to point out to the coach how much progress a person made. And I'll say, gee, their baseline score was X, and now at session 8, they're down to whatever it is. Point out that that's a really significant improvement. Sometimes the scores don't change as much as we might have wanted, so you have to think of other ways to sort of summarize the good work that has happened. So that might be focusing on insights that the person gained about himself or herself, or even their understanding of depression. If nothing else, the repeated use of the PHQ-9 has taught most people what the basic symptoms of depression look like, and ways to know when it's getting worse. Even if the depression might not have improved, people often did feel like they learned the skills and the techniques. And so separating those two is important. A lot of the training that I do for residents and students, we talk about mastery and enjoyment. It's great if you can master something and enjoy it, but a lot of times you can enjoy something even if you're not a master of it. Early work, residents and training don't enjoy a lot of what they're doing, but they are getting better at it. So even if the person didn't improve their depression score, they may very well have mastered some of the techniques that you taught, and you can go over that with them. I think this repeats what I said before about decrease in symptoms. If they got worse, that becomes an opportunity. You've now worked through it, but reminding folks that if you had a relapse, that's a useful thing to remind somebody about, because it may mean that they're going to have a future relapse. relapse and preparing them for that and planning with them in this last session what to do about that if it were to happen again can be very helpful for them. Last bullet point again goes over what to do if there was no clear decrease in the score. What I find as a supervisor is, and you will want to, I think, preview this for your trainees, is that you don't want to overly personalize this. Again, in the way I think about my work, if I am truly trying to work with the right people, I'm going to have a lot of successes, but I'm going to have some people that I can't help because I'm trying to take on all comers. I'm not trying to just cherry pick the people that I know will be successful. And in doing this work, you're just going to come across people who don't always improve as much as we would want, but it doesn't reflect on you being a poor coach. After teaching the coach to give their own perspective, I think it is very helpful to remind the coach to let the participant do the same thing. I think it's important for a couple reasons. Sometimes the client will in fact have insights and things that they appreciated about the process that the coach would have never guessed, and that really become very reaffirming for the coach to hear about. So giving the client the space to do that is, I think, really important. The last thing we want to try to do is to, again, hit home the core components of PEARLS. This is, in fact, maybe the last time to go over this with the client. And so it goes back to probably something that you will have talked about in your training in the much earlier sessions in terms of the theory behind PEARLS as an intervention for depression and the cycle of depression. So talking about the fact that we've tried to teach people what symptoms are, that the symptoms are due to depression and not due to personal flaws or failures that people bring into their beliefs about why they are depressed. That there is this link between depression and unsolved problems, and what you've tried to teach people to do is to use a method for solving problems, and that if they can do that and then add on some physical activation, social activation, and pleasant activities, that's what leads to depression improvement. And again, it's something they can do in the future, even when the actual work with the client will have stopped. The client hopefully will take these to heart and be able to use them independently. This again just breaks it down into the individual components that they've gone over in every session. You can have the problem list. You can have your coaches review not just one problem, but many things that might have been on the problem list. And they can be reminded of many types of activities that they engaged in that were helpful, both pleasant events, physical and social activities. In the end, you're going to summarize the person's achievements and remind them that they can use these things in the future as future problems arise. I think it's a fair thing to teach people that depression really is a chronic and recurring condition. And if you've had a significant depression, the chances that you will have it again are now much higher than the general population. To normalize that for people so that they don't think, again, something must be wrong with me because this is coming back. As a final touch, we encourage you to remind coaches to leave blank worksheets. Sometimes clients actually ask for the worksheets. But to the extent that people have been taught to use the worksheets independently, leaving the worksheets with them can be very helpful. leaving the PHQ-9 so that they can remind themselves of the specific questions and symptoms can be helpful. And then adding on whatever the agency is wanting in terms of documentation to complete a final session compared to a baseline session. What we list here is that we have a final questionnaire that we've socialized amongst the trainings. There's a satisfaction questionnaire. The agency that the coach is working with, though, may have their own list of things that they want to get data on. And so this is, again, the session that they're going to have to discuss that and to get that done. Sometimes we get asked about leaving it versus having it mailed versus completing it in real time with the client. And what our experience has been is you're much more likely to get it back if you leave time for the person to complete it while you're with them than if you leave it and then are hoping that they will mail it back to you. So for what it's worth, that's, I think, just part of human nature. Questions about that? Okay. When to graduate people early? This comes up. So session 8 is traditionally the last session, but it's not always the last session. And so we have tried to give some basic guidelines when you teach and train on the way to think about graduating people early. I think you want to know that the person has had a significant improvement in their PHQ-9. Again, remission is the goal. A 5-point drop would be probably the smallest clinically meaningful degree of change, but we really are trying to treat depression to the point of remission. What I think coaches that I work with don't always remember is that it's not just that the person got better. If they got better, but they didn't actually learn to use the skills independently, that's the reason to have gone through the other sessions. And so I often have tracking sheets where it's pretty clear by session 3, the person's score has dropped pretty significantly, but that's not a time to stop. And if the coach asks me, well, can I graduate this person early? The first question I ask them is, does this person really know how to do PST and behavioral activation on their own? And if the answer is yes, then that's now a candidate for graduating early. But if they really don't know how to do this on their own, then that's why we're going to continue to do the sessions, even though their score may not get much lower because they've already had a significant improvement. Lastly, I always defer to clinical supervision. So with my coaches, I always tell them that they should be talking to me about anybody that they plan to graduate early. Questions about that? The other question that you may get is, well, what happens if the person wants to stop, but they haven't met these criteria for graduating early? So what do you think you would recommend they do in that scenario? Any thoughts? And Gesundheit answer, I could see you're sneezing. So any thoughts on what to say if somebody is wanting to stop, but they've not, let's say, learned to do PST and behavioral activation on their own? Yes, Cynthia.
I'm sorry, if nobody speaks, I have to talk. You know what, when people want to graduate early, I say to them, okay, let's go through the worksheet and you show me, you teach me. You know, you teach me how to use the worksheet. Well, and then that tells me more about where they're actually at. You know, like you guys do, you know, you teach us and then we're asked to teach you. So I do the same thing in reverse with my, we call them participants.
Yeah.
With my participants, I say, you show me how to use that worksheet. What does it mean to you? You know, and then most of the time they say, well, maybe we, you know, if we discuss it, maybe we need a little more time.
Yeah. Okay, I think that's perfectly reasonable. I think the other thing that I try to teach my coaches is the client always has the right to stop. And so what we're really talking about here is not whether they're going to stop, because if they want to stop, they don't have to give me a reason at all. They just have to say, I don't want to do this anymore. What we're really talking about is, are we sort of encouraging that and saying that that's a recommendation, or we're simply respecting their wish? And so I don't want my coaches to get into arguments with people over this, because if what's really at hand is the client wants to stop, we're going to respect that wish, but we're going to make it clear that that's not what we recommend. But out of respect for their wish, they are allowed to stop. And then we're going to record it in our system is that they asked to withdraw from the program, and that's the way it happened. It's not that we graduated them early. Let's go ahead. In summary, we've talked about suicide and self-harm. We've talked about the supervision, and we've talked about the final sessions. I think I've given chances after each of these for questions, but any questions about the final session or anything that we've covered so far? Okay. FAQs. I've tried to give you some hint at FAQs that I get when I've gone over these types of sessions, but let's just see. Teach back. Anybody want to take a shot at volunteering to describe the action steps that the counselor would need to be taught to go through in dealing with a suicidal client? And I'll give you a minute to prepare, but I need to know who would want to volunteer for this teach back.
I can do either if
All right,
someone else has like a preference.
all right. Anybody else? So hearing none, maybe I'll see. Dina, you feel comfortable going over the rationale for clinical supervision?
Sure.
All right, so I'll give you each a minute or so to think about what you want to say with that.
Going back to my action step slide.
Sure.
I'm going to take notes, ladies.
I think I'm good whenever works for people. I think I found it, so.
So take it away, Allison.
Okay. So when we have clients in Pearls who express some kind of suicidal thoughts, or you might hear suicidal ideation, it's important for us to know as Pearl counselors what we can do next. So this is a good time where first we want to make sure that we're assessing for their level of risk, because there's some different, I guess, categories that people can fall into. And so here at Traeger, often we have a risk assessment that we have within the chart or also a Word document. We don't use our medical chart actually to document Pearls, but that we can utilize and that we've templated for you. But it also helps us assess, if they're having thoughts of suicide, do they have a current intention for harming themselves? And if they are kind of having some kind of intention, have they planned specifically perhaps how they're going to do it? Is there a place or a time that they're planning to do it? So kind of assessing the level to which these people have thought about these things, and also if there's any kind of planning or perhaps means, any kinds of firearms or maybe other things people could use to harm themselves. So we want to make sure that we're kind of walking through those different things with them. And also if any actions have been are being taken now to carry those things out, we're also assessing maybe past risk if you haven't already. Have there been attempts in the past as well? Because all these things can inform our decisions about what to do next. So, of course, we as your, I supervise students just generally. So we as your supervisors and also as your Pearl supervisors are here for you, and your Pearl's clinical supervisors, which would be in our case, our psychiatric nurse practitioner, Mary Beth Cody, are here for you to help walk you through these things. But we also just want to make sure that you have access to that risk assessment so you know how to start evaluating. So after we've kind of done that, we want to make sure if that person is more in a suicidal ideation sort of a place, we want to make sure that we develop a safety plan with that client. We have a template for that as well. And that'll help them assess their natural supports and also maybe local resources they can access to help minimize their risk and help them be safe. In some instances, unfortunately, although it's rather rare in my experience, some people may need a little bit more than that, and there might be more present danger to them. And so we might need to take further steps, such as maybe connecting them with their local emergency room or emergency department, wherever they may be. Calling the police. Here in Louisville, we have a crisis team of people trained in mental health who are on the police force who can come and take people to the hospital if that's needed. So just making sure that we are assessing that risk properly and taking the next steps for that. So it's also a good time if people are having these kinds of thoughts just to ask if they've informed other providers, whether those might be providers at our clinic or maybe other people that they see. And if they haven't, it's okay to check in and ask if maybe that would be okay for us. So that way we have other providers that are kind of know what's going on and can assist that person, especially if maybe they're their mental health provider that they see. So another good step, and this can also be part of our safety plan too, is to make sure we provide emergency crisis line numbers for that person. So we have a national one that's provided on your safety plan templates, and also a local line that you can also utilize. And some people may have a preference, so they can use either though. And once we've kind of taken all these steps, we want to make sure that we're providing those steps in our case notes. So making sure we're documenting all of those and reviewing with your clinical supervisor as needed so that they're also in the loop. And we're making sure that we're doing our part to help keep people safe, and if necessary, informing people that need that. And scene.
That's great. That's great. Excellent. Comments for Allison?
Allison, great job. The only thing I would add would be to let people know that just because you ask about it,
Mhm.
mean that that will make them want to do it. I think a lot of
Yeah.
people are scared to death of the PHQ-9, that ninth question. They want to avoid it or sidestep it somehow. So,
Mhm.
it doesn't mean you have a plan because you've asked about it.
Mhm. Yeah, no, that's a good thing for me to remember. Thanks, Cynthia.
All right, Dina, you want to give us your take on the second practice item there?
Sure. And I took some notes on the rationale, not so much on the points to cover, but I'll do my best to just recall. So I think, as was already pointed out earlier, that this can be the piece that can be the most daunting for organizations to consider, knowing that they have to locate somebody that can provide clinical supervision to oversee this program. And I think because of that, it's extra important to kind of lay out the reason why it is important, so that they understand what the expectation is. So really, some of the benefits and rationale for having clinical supervision as part of PEARLS is just to give some kind of additional perspective on complicated patients. Assuming that we're having a diverse population that we're working with, we're going to work with some people that are referred for depression with pearls that will have varying degrees of complications. And so having a more experienced provider that has some different diversity and perspectives on dealing with patients with depression is very important to kind of making sure all of your bases are covered. Also, because these folks will come to this role with a different set of perspective, they also kind of are a step removed from the process, so they can provide kind of that perspective. Let's see, and also just taking apart, I know in our agency, a lot of the folks that we are training to be Pearls counselors have a lot of experience more in case management. And so kind of having that medical perspective to balance out just the case management perspective in working with folks can kind of give a better balance to the experience, and also to managing how people are progressing throughout the course with Pearls. Also really important is just the liability consideration. Allison just presented on how we're going to manage folks that may be suicidal, and that can be really scary for people, as we mentioned, to be dealing with that population. And having a provider that has more experience and expertise in dealing with that management can be a really important piece of the puzzle, to have somebody that you can go to for advice when you come across these kinds of situations. And then lastly, just because it really does present an opportunity for ongoing training and for deepening our knowledge on how to interact with people. Getting the opportunity to further develop your skills, because we're reviewing cases in a group and having the perspective of a supervisor, it can really help us sharpen our skills, process what's going well, what's not going well, and can kind of make the whole program as a whole advance. And so that's pretty much what I took notes on in terms of that piece.
That's great.
Yeah.
That's great.
And in terms of the key points to cover during case review, I know that I recall you speaking to the fact that having the patient's age is important. Also knowing kind of where they are with their depression, kind of what their initial score was with the PHQ-9. I also thought in the slide that you presented, it was very helpful to know the specific symptoms within the PHQ-9. If someone is suicidal, but they still have, I think I appreciated that in your slide, kind of giving not an overview just of the PHQ-9, but particular areas. Also where they are in terms of their problem list. And how they have been engaging with that so far, any kinds of setbacks that you've noticed with the patient where they're struggling, just to be able to have the benefit of some more instruction about how to maybe progress with a particularly complicated patient.
Yeah, I think that's exactly right. I think the presentation piece is the least important. I think, again, that's going to be much more locally driven. I think making the rationale for why they need to go to the time and effort and expense of getting the supervisor is really the key point. In fact, you got that down exactly right. So other thoughts?
Great job, Dina. Explaining like the why behind the need for this, and you broke it down really in a way that would be easy to understand, like why this is so important. If I was like an executive management person at a CBO bringing this program in, like you explained it in a way that was really easy to understand.
Okay. I see we're at time, so I'm just going to go over a couple last things, and Caitlin can remind me if I'm forgetting something. Or were these the slides that you wanted to go over, Caitlin?
Sure, that's fine.
Okay.
All right, so as now having just about completed your trainer training, we do recommend and really would like you to conduct a training within 6 months if you're able. Certainly, I think for Dina and Allison, with all your students, you'll have ample opportunity. We may call on you to see if you're available and interested in training or co-training some of the stuff that we work on. We're not planning to host traditional trainings anymore, but we may have opportunities for you to practice your training chops. This was sort of back, the idea here was when we were still when most people were offering in-person trainings. So just be in touch with us as you're thinking about training. And then when you do train folks, even if it's students, we'd love to get a roster of their organization, their contact info, email, both so we have an idea of where new Pearls programs are starting up, and so I can add them to the monthly TA call emails. So we will be sending you a knowledge assessment, which includes a brief quiz and written evaluation. And then, oh, sorry, I was sort of jumping around here. I was thinking that the trainer training was for something else. So after your first in-person training, you will have an opportunity to evaluate each other if you co-train with somebody. We have a self-evaluation tool that you can use to see how you think you did. And then we always recommend that you get evaluations from the trainees. We always collect that data. I mean, we love data, but it also helps improve how you're presenting the information, the information that you are sharing, and think about future trainings, what resources and tools they might find, or future trainees may find helpful. So I think that's about it. So thank you, congratulations. You're almost there as soon as you complete your quiz. I believe it's just a Word document that I'll send out. I need to check with, Leslie's out today and tomorrow. I need to check with her to see if she had any final changes to that. But we'll send it along with instructions by email.
So we don't have the 4-question thing that,
Well, double check the PH Learn link because we sort of went out of order because of Mark's schedule and my schedule. So there may still be some stuff showing up in the, I think this is module 5 on the PH Learn link website because we rearranged 5 and 6 for our schedules. So double check, there may be a couple questions. But
module 5. Okay.
Yeah.
I think I did that one.
you might have,
Last week.
but always feel free to reach out to me anytime. And if I don't know, I'll ask Leslie. And if Leslie doesn't know, we'll ask Mark. So,
All right, so if I don't do them, let me know if I missed one.
yeah, of course. All right.
Thanks, everybody. It's a pleasure meeting you all.
Thank you.
Thank you.
Okay,
Nice to meet you all, everybody. Good luck.
Good luck.
You too.
bye-bye.
Bye.
Bye. Thanks so much, Caitlin.
You're
This
very
was
welcome.
wonderful.
Good.
Dr. Snowden, thank you.
Sure thing, Cynthia. Talk to you soon.
I love this program. This is the best ever.
Excellent, excellent.
Thank
All right,
you.
we'll see you soon.
See
Thanks,
you.
All right. Thanks, Mark.
Bye, guys.
Bye-bye.